Hi, everyone. My name is Pooja, and I'm a third-year plastic surgery resident. Today, I will be presenting our randomized controlled trial of Apixaban versus Enoxaparin for chemoprophylaxis for venous thromboembolism, or VTE, in plastic surgery. The authors have no relevant disclosures. Venous thromboembolism, or VTE, remains an important patient safety issue in plastic surgery, especially when considering high-risk reconstructive surgery populations, such as cancer and trauma patients. Baseline propensity for hypercoagulability in these patients, in combination with lengthy reconstructive procedures, makes VTE a non-negligible source of severe postoperative morbidity, with the literature demonstrating that there is up to a 20% rate of asymptomatic VTE in breast cancer patients undergoing autologous reconstruction. Furthermore, multi-center data has demonstrated that 1 in 25 patients with elevated Caprini scores in plastic surgery experience breakthrough VTE events. In addition to the clinical morbidity associated with this issue, there's also a cost, with the average cost of DVT treatment quoted at $10,000. As such, there is a pressing need to optimize VTE chemoprophylaxis in high-risk plastic surgery populations. Although the current standard of care for VTE chemoprophylaxis in plastic surgery is enoxaparin, there are multiple limitations with this drug. First, its need for weight-based dosing. Second, the need for factor Xa monitoring to ensure adequate therapeutic levels. And third, the need for subcutaneous injection, which is uncomfortable for patients. The first two can result in inadequate dosing and duration of therapy, while the third can result in limited patient adherence due to issues with discomfort and inconvenience. Apixaban, which is a direct factor Xa inhibitor, can address many of these shortcomings given its oral formulation and its simplicity of dosing, without the need for drug-level monitoring. In fact, Apixaban has been demonstrated in landmark orthopedic surgery trials to be superior to enoxaparin in terms of VTE chemoprophylaxis without increasing the risk for bleeding events. As such, we investigated the safety of Apixaban VTE chemoprophylaxis in plastic surgery patients via a non-inferiority trial against enoxaparin amongst high-risk breast cancer patients undergoing autologous reconstruction. Safety was defined with regards to postoperative bleeding events. As a secondary objective, we investigated the rate of symptomatic VTE in these patients with regards to Apixaban versus enoxaparin. Ultimately, we hypothesized that Apixaban would be a safe and effective oral alternative for enoxaparin for VTE prophylaxis in autologous breast reconstruction. This is a first-of-its-kind randomized controlled trial of DOACs in plastic surgery, and through our work, we hope to move the needle in improving VTE chemoprophylaxis in this field. This was a single-center, blinded, randomized controlled trial of Apixaban versus enoxaparin. Patients were breast cancer patients undergoing abdominal free flap breast reconstruction with Caprini scores greater than 7. Patients with a history of coagulopathy or who required heparin drips postoperatively were excluded. Patients were assigned to study group and PACU, and thus surgeons were blinded to group at the time of surgery. Study outcomes were investigated on an intention to treat basis. In total, 37 patients were randomized to the Apixaban arm versus 39 to the enoxaparin arm. Study groups were similar in terms of baseline demographics, comorbidities, and reconstructive details. In terms of bleeding events, there were 2 events noted in our cohorts, one in the Apixaban group and one in the enoxaparin group, with an adjusted odds ratio of 1. The secondary outcome of interest was incidence of symptomatic VTE within the 90-day postoperative period, and there were no symptomatic VTE events noted in either group. In terms of total complications, there were 5 patients with complications in the enoxaparin group and 6 in the Apixaban group, with an adjusted odds ratio of 1.1. A majority of these complications were surgical site infections or mastectomy skin necrosis, all of which were managed non-operatively. In conclusion, Apixaban was found to be non-inferior to enoxaparin in terms of postoperative bleeding events, thereby establishing its safety as a VTE chemoprophylaxis agent. The rate of postoperative bleeding in the enoxaparin group corresponded with the published rate in the literature, and the Apixaban group was non-inferior. In addition, neither treatment arm had any symptomatic VTE events. Apixaban represents an important paradigm shift in VTE chemoprophylaxis in plastic surgery by serving as an easy-to-administer and well-tolerated alternative to enoxaparin. This is especially important as breakthrough VTE events remain relatively prevalent despite chemoprophylaxis. In addition, high-risk plastic surgery cases are rising as more cancer and trauma patients seek complex reconstructive procedures, and the safety of Apixaban is now increased given the widely available reversal agents in most hospitals. Of course, the study was not without limitation. As a single central trial, the external validity may be limited. However, we did use standard operative techniques, and patients were collected across multiple providers, thereby increasing generalizability. In addition, our study was not powered to our secondary outcome, as this study was mainly designed to investigate the safety of Apixaban chemoprophylaxis. And as such, in future trials, we hope to investigate this issue in a multi-center approach, and also power our trials to symptomatic and asymptomatic VTEs that are detected only by imaging to get a better understanding of the relative efficacy of these two drugs. And as such, with all medical innovation, we would also like to investigate the cost effectiveness impact of this switch. Thank you so much to the Stanford Division of Plastic Surgery and to the Stanford Department of Surgery for allowing us to present our work today. Thank you so much.